you're okay with that.
Sure, no problem. Thank you, Alison. Thank you, everyone. I have been following this group for about 2 years now, and it's been very interesting. So I'm going to share some of my work now, and I thank you for this invitation. Let me see. So can you all see the presentation? I think so. Okay. So the title is Biofluid-based biomarkers of neuropsychiatric symptoms in dementia Lewy bodies and Alzheimer's disease. This was my postdoctoral fellowship that ended about 2 years ago. And I have published only one paper so far on the biofluid-based biomarkers and a few others on neuropsychiatric tests. But I'll present to you the results of the first paper on biofluid-based biomarkers that I published. And I think the link was shared in the document that everyone received. These are my disclosures. None of them is relevant to the presentation. Sorry. I'll speak closer to the microphone. I think you'll hear it better now. So behavior features may reflect underlying amyloidogenesis and neurodegeneration dementia syndromes. And these mechanisms are potentially measurable by biomarkers. We can have biomarkers in blood, in cerebrospinal fluid, in several different body fluids. And we hope we can measure these mechanisms, and they are modifiable by pharmacological therapy. We must remember that amyloidogenesis is a neuroprotective mechanism that starts very early in life. It's a response to oxidative stress, trauma, infection, inflammation in general, and these aggressive mechanisms, they start generating amyloidogenic mechanisms in the brain that aim to protect the neurons against this stress. However, when production of amyloid is excessive or when clearance of amyloid is insufficient, we have a problem because amyloid starts to accumulate more than we would like. And further on, the accumulation of amyloid also leads to tauopathy. It's important to know that amyloidogenesis, the amyloid plaques are usually extracellular, while tau tangles are intracellular in the neurons. So there's a topographical feature here that we must keep in mind. So the two main pathological features of Alzheimer's disease, as we have been aware of for a long time, are the amyloid plaques, which, as I said, are extracellular, and the intracellular tau tangles. This is a pathological picture from this article that I think illustrates very well what happens in Alzheimer's disease. Now, dementia Lewy bodies is a little different because, first of all, pathologically speaking, there's the formation of Lewy bodies, which are intracellular bodies that are mostly composed of alpha-synuclein. And the Lewy body dementia syndromes, they have some core features, such as visual hallucinations, fluctuating levels of attention, the REM sleep behavior disorder, and Parkinsonism. We have two main types of Lewy body dementia syndromes, which are dementia Lewy bodies, which is predominantly a dementia syndrome that later on has Parkinsonism as one of its main features. And we also have Parkinson's disease dementia, which is a form of Lewy body dementia syndrome that starts with Parkinson's disease, and later on patients develop dementia. We have several papers in the literature that show differences between patients who have Alzheimer's disease and dementia Lewy bodies, and also Parkinson's disease dementia. This is one example from a group that we published in 2015. I just wanted to show you that some features are different among these patients. So, for instance, we have here lifetime living with sanitation was much longer for patients who had Alzheimer's disease than for patients with Lewy body dementia syndromes. This is an epidemiological study, so we don't know what that means yet. We don't know if an environmental feature could affect the development of Lewy body dementias, but it certainly suggested, as well as the history of treated systemic bacterial infections, which was much higher in patients who had Lewy body dementias than in those who had Alzheimer's disease. And on the other hand, systolic blood pressure was higher in patients with Alzheimer's disease than in patients with Lewy body dementia syndromes. which is a feature that shows how much vascular risk factors are important for Alzheimer's disease. Here we have some other features between patients with dementia Lewy bodies and Parkinson's disease dementia. So for instance, we see that the length of Parkinsonian syndrome is much higher for patients with Parkinson's disease dementia than patients with dementia Lewy bodies, and they are more impaired in terms of functionality than the patients who have dementia Lewy bodies. We see that the scores for the Schwab and England scale, which is a functional score for Parkinsonian syndromes, and the scores on the Index of Independence and Activities of Daily Living, they are usually more impaired in patients who have Parkinson's disease dementia than in patients who have dementia Lewy bodies. A few other features might help differentiate Lewy body dementia syndromes from Alzheimer's disease, such as, for instance, the use of levodopa, which we didn't have any patients with Alzheimer's dementia who use them. Patients with Alzheimer's disease can also have Parkinson's disease, but in this case, it didn't happen. We also have the functionality, which is usually more impaired in patients who have Lewy body dementia syndromes than in those who have Alzheimer's disease, even though cognitive scores were not significantly different among the two groups, between the two groups. So functionality is usually a result of the motor impairment in Lewy body dementia syndromes, and it usually declines faster than in patients who have Alzheimer's disease. And in terms of behavioral features, we have a few differences. So for instance, hallucinations are much more frequent in dementia Lewy bodies and much less frequent in Alzheimer's disease dementia. It usually starts very later on in the disease course in Alzheimer's disease dementia. We have apathy for all the groups, but patients with Lewy body dementia syndromes can have even more apathy than patients who have Alzheimer's disease. And dysphoria, which is a feature of depression, can be very high in patients who have Lewy body dementia syndromes, and is also a supportive diagnostic criterion for Lewy body dementia syndromes. But it's also high in Alzheimer's disease dementia, and it can also happen throughout the disease course. So the learning objective here is to evaluate cross-sectional associations of cerebrospinal fluid biomarkers of amyloidogenesis and neurodegeneration with behavioral features in dementia Lewy bodies compared to Alzheimer's disease. And we also have a control group of cognitively healthy people. They were older people, they were paired according to age, so that we could have a match by age in all the three groups. We're going to base ourselves in this article, which is the article that we recently published in the Journal of Alzheimer's Disease. The original timeline for the study was 2 years, but we had to add an additional year to do all the tests, so the study took 3 years to be completed, and the budget was around $150,000 in the end. So we had consecutive outpatients with probable dementia Lewy bodies, according to the fourth consensus report of the DLB consortium, and they were paired with outpatients who had late-onset Alzheimer's disease according to the 2011 NIA Alzheimer's Association criteria, and they were also paired with cognitively healthy controls. We paired patients with dementia syndromes by way of sex, clinical dementia rating, and mini-metastatic examination scores. While pairing between patients with dementia Lewy bodies and cognitively healthy controls was done by sex and age, more or less 2 years. So patients with dementia syndromes were more or less in the same dementia stage, while controls and patients with dementia Lewy bodies were paired according to sex and age, so that we would have a proportion of sex that was equal in all the three groups, and according to age, so that we would have a similar age in all the groups as well. This is the guideline that we used for cerebrospinal fluid collection biobanking. It's the guideline from 2009. The first author is Charlotte Nissen, who is the current chair of the Biofluid-based biomarkers PIA of the iStart. And it has all the most important features that we have to look for when collecting and biobanking cerebrospinal fluid. So we measured cerebrospinal fluid concentrations of amyloid beta 42, which reflects the amyloid beta in the amyloid plaques, amyloid beta 40, which reflects the amyloid beta in the entire brain, and amyloid beta 38, which is more specific for dementia Lewy bodies, as we're going to show later on. Tau and phospho-tau. Phospho-tau, we had it in the position 181 of the 309. alpha-synuclein, ubiquitin, and neurofilament light, which were assessed by enzyme-linked immunosorbent assays. We also genotyped our patients for these two SNPs, which are related to the APOE gene, with Taqman real-time PCR technology. This is a paper from 2011, which showed that CSF amyloid beta 38 was more specific for dementia Lewy bodies. This is not an universal finding, but this is why we decided to measure amyloid beta 38 as well as amyloid beta 40 and 42. This is one of the papers that is available in the literature showing the correlations of alpha-synuclein and Lewy body-like symptoms in mild cognitive impairment and Alzheimer's disease, and they found that lower CSF alpha-synuclein is associated with more hallucinations and Lewy body-like symptoms in Alzheimer's disease. And this is a paper from the Journal of Alzheimer's Disease as well that shows that it's possible to differentiate some groups of patients who have Alzheimer's disease according to amyloid beta 42, ApoE4 carrier status, and tau and ubiquitin. So that's why we decided to measure ubiquitin as well. Biomarkers and biomarker ratios were associated with hyposmia and behavioral domains of the neuropsychiatric inventory. We decided to associate it with hyposmia as well, because the subjective sense of smell is usually reduced in synucleinopathies, such as Lewy body dementia syndromes, and we wanted to see how well this associated with the biomarkers. Our analyses were adjusted for sex, years of education, age, estimated duration of the dementia syndrome, number of ApoE4 alleles, and use of psychotropic drugs, so that we wouldn't have an influence of psychotropic drugs over the neuropsychiatric symptoms. So in the end, we had 27 participants with dementia Lewy bodies, and 11 of them were ApoE4 carriers. They were paired with 27 participants with Alzheimer's disease, and 12 of them were ApoE4 carriers. Then we also had 27 controls, and 4 of them were ApoE4 carriers. The mean scores on the neuropsychiatric inventory were higher for dementia Lewy bodies than for Alzheimer's disease and controls, particularly regarding apathy and hallucinations. So these are the most important anthropometric and demographic variables of the patients. We had an exact matching according to sex. 2/3 of the patients and controls were women, and one-third were men. Their ages did not differ significantly, but it's important to see that these patients were usually older than what we see in the literature. The mean age was 78 for dementia Lewy bodies and 81 for Alzheimer's disease and 1 year old. Levels of education were higher for Alzheimer's disease than for dementia Lewy bodies, but they were overall a little lower than it's usually seen in the literature, because patients were born in the first half of last century in Brazil usually didn't study many years during their lifetimes. The age at dementia onset was similar for both groups of dementia syndromes, and clinical dementia rating sum of boxes scores were similar for dementia syndromes, but were much higher than cognitively healthy controls. The distribution of ApoE haplotypes was not significantly different, but we had only 4 controls for ApoE4 carriers, and 12 patients with Alzheimer's disease and 11 patients with dementia Lewy bodies. Regarding behavioral domains, there were significant differences in many of them, particularly concerning the fact that patients with dementia Lewy bodies have more behavioral impairment than patients with Alzheimer's disease. So they had more agitation, more hallucinations, more anxiety, more apathy, more delusions, and more dysphoria. Also, aberrant motor behavior and nighttime behavior disturbances were significantly different. These are the biomarkers for ApoE4 carriers. So we see that there's not much of a difference among the 3 groups, probably because amyloidogenesis, which is affected by ApoE4 carrier status, is usually high, not only in Alzheimer's disease, but also in dementia Lewy bodies, and even in cognitively healthy controls in patients who are older, who are older than 70, 80 years old. We also see that tauopathy was similar among the 3 groups, and also the ratios that we measured for them. One important thing is that neurofilament light was lower for dementia Lewy bodies than for Alzheimer's disease in cognitively healthy controls, even though there was no significant difference here. However, for ApoE4 non-carriers, we had neurofilament light that was higher. that was higher for dementia Lewy bodies than for ApoE4 carriers. So there was a difference regarding ApoE4 carrier status for dementia Lewy bodies. Another interesting thing is that the amyloid beta 42, amyloid beta 38 ratio was significantly higher for dementia Lewy bodies than for the other groups, only for ApoE4 non-carriers. Measures of tauopathy were not significantly different, and we also found that alpha-synuclein over amyloid beta 42 was significantly lower for dementia Lewy bodies than for the other groups. Other results were that only patients with Alzheimer's disease had mean tau over amyloid beta 42 over 0.52. This is a finding in the literature that shows that the sample is well characterized. So patients with Alzheimer's disease had higher tau over lower amyloid beta 42. ApoE4 carrier status affected A beta 42 over beta 38 and determined similar tauopathy for both dementia syndromes, particularly for ApoE4 carriers. And ApoE4 carrier status influenced alpha-synuclein over A beta 42, but not tau over alpha-synuclein in dementia Lewy bodies. This probably happens because tauopathy in dementia Lewy bodies is more similar to Alzheimer's disease and less affected by ApoE4 carrier status than amyloidogenesis. So considering that A beta 42 would be lower for ApoE4 carriers, then alpha-synuclein over A beta 42 would be higher in dementia Lewy bodies, but it didn't happen for tau over alpha-synuclein. The levels of neurofilament light were affected by ApoE4 carrier status only in patients with dementia Lewy bodies. We must remember that neurofilament light is a measure of large caliber axons, in that it's not specific for any neurological disease. So it can be higher in dementia syndromes, it can be higher in Parkinson's disease, it can be higher in multiple sclerosis. So several different neurological diseases can affect levels of neurofilament light. But the ApoE4 carrier status only affected these levels in patients who had dementia Lewy bodies. Isolated biomarkers were not useful to distinguish dementia syndromes in this study, possibly due to underlying amyloid pathology in all participants because of their older age. But it could also be due to a modest sample size. This is more of a preliminary study with a considerably small sample size. And so it's possible that isolated biomarkers were not significantly different because of that. But their ratios were more important than isolated biomarkers. And these are the associations with specific neuropsychiatric symptoms. Not all of them survived multiple correlations. So for dementia Lewy bodies, we have important here that hallucinations were associated with measures of amyloidogenesis and with measures of phospho-tau over amyloid beta 42. And dysphoria was associated with tauopathy and alpha-synuclein over amyloid beta 42. Another important difference is with regard to hyposmia, which was more prevalent in patients who had less amyloidogenesis, according to indirect measures of the cerebrospinal fluid. And for Alzheimer's disease, we found more associations, but the most important ones were the association of agitation with tau. Aberrant motor behavior was associated with neurofilament light, with lower neurofilament light here, and with amyloidogenesis. And nighttime behavior disturbances were associated with tau over amyloid beta 42 and with phospho-tau over amyloid beta 42, and also with alpha-synuclein over amyloid beta 42. So in conclusion, biomarker ratios were superior to amyloid beta and tau biomarkers predicting neuropsychiatric symptoms when these associations were not significant, but they were similar when these associations were significant. So in general, we should try to use biomarker ratios instead of isolated biomarkers because they're usually more specific and they are more reliable. ApoE4 carrier status influenced amyloidogenesis and tau pathology in both dementia syndromes. In the associations of measures of axonal degeneration with neuropsychiatric features were observed only in patients with Alzheimer's disease. In this case, we're talking about neurofilament light, which is a measure of axonal degeneration. Future prospects are the associations with pharmacological therapy. So we can measure these associations according to specific drugs that are used for therapy, such as cholinesterase inhibitors, memantine, but we are also aiming at associations with angiotensin converting enzyme inhibitors, angiotensin receptor blockers, because there are reports in literature that they can affect cognitive decline. And there are some reports about the associations of angiotensin converting enzyme genetic variants with monoamine metabolite concentrations in cerebrospinal fluid, which can be affected by psychotropic therapy as well. I'd like to thank our sponsor, the State of São Paulo Research Foundation, the Agreed Dementia Group for this invitation, and my colleagues from the Federal University of São Paulo. So thank you very much. If you have any questions, then feel free to ask them from now on.
So Fabrizio, a lot of people were saying they were having trouble hearing you. I know